afternoon to the two moderators and for the audience. My name is Xuxuelin, and I'm from Taiwan. And this is my great pleasure to have the talk here. And also, this is my first time to have the oral presentations. And right now, I'm the urologist. I'm the chairperson under my first year's residentships. And today's my topic. I'm going to modify my topic. My topic is the human polyomavirus is associated with earlier onset of urinary tract urothelial carcinoma in patients after kidney transplantations. And first, when it comes to the renal transplantation patients under the immunosuppressive therapies, we might encounter two problems. One is the infections, and the other one is the malignancies. And nowadays, the new infectious agents like the BK polyomavirus, hepatitis E virus, parvovirus, and this kind of the agents, they strongly will compromise the effective status of the immunocompromised hosts. So the human polyomavirus was first isolated in 1971, and there are two types of the human polyomavirus. One is BK virus, and the other one is the JC virus. And the polyomavirus was first isolated from the urine of the immunocompromised renal transplantation patients. And after transplantations, BK viremia might occur, and the incidence of the BK viremia occurred is about 99.5% in the first year, and 2.0% in the second years. And when BK viremia occurred, it may compromise the growth renal functions, and the overall growth failure rate was the 50% to the 80% within the 5 years. However, the BK incidence did not differ from the below. Did not differ from the donor's or recipient age, or whether it's diabetes, or previous transplantations, or whether it's a living donor or cadaveric donors, or the immunosuppression agents we choose. So from our hospitals, from 2005 to 2014, there are 27 patients who was found upper urinary tract urothelial carcinoma after kidney transplantations, and all 27 patients who were underwent extended nephroureterectomy. And for all the specimens, we were exempt for the large tumor antigen expressions. The reason why we exempt for the large tumor antigen because this is the BK virus early genes that encodes the large tumor antigens. So that's the reason why we exempt. And after the nephroureterectomy, our follow-up protocols was do the fibrocystoscope and mineral echo periodically, and the abdominal CT image annually to see whether the patient has the distant metastasis or not. And this is our result. For the patients we have, there are 7 patients have the large tumor antigen positive, and 20 patients have a large tumor antigen negative. And for all the parameters we can solve, only the edges has a meaningful steady state factors. For the patients who have the positive large tumor antigens, they were younger. They were 48 years old compared to the negative group. They are 54 years old. And when it comes to the follow-up durations, when the genders, all the transplantation to malignancies, there were no difference between these two groups. In addition, the pathologic features like the non-vascular, like the multifocal or the high grade, and also the oncologic outcome like the better tumor recurrence or distant metastasis, there were also no difference from these two groups. But we can see for those two groups, there are still patients that have the distant metastasis. So we want to assess why is there any associated factors for the patients who have the distant metastasis. We found there are 2 associated factors that associated with the distant metastasis. The one is the whether the tumor is organ confined or not. We can see the blue line, it is the tumor is organ confined, and the green line is the tumor non-organ confined. And the second is whether the patient they have the lymph node vascular invasions or not. The blue line is the negative for the lymph node vascular invasions, and the green line is the positive for the lymph node vascular invasion. So we found that there's significantly younger ages in patients with the positive polyomavirus large tumor antigens in UTUCs. However, we did not find an obvious difference for the pathologic features and the oncologic outcomes. And there were two prognostic factors for the distant metastasis. One is the patient, whether it's organ confined or not, or whether it's positive for the lymph node vascular invasions. So which kind of the patients that tends to have the BK virus, means where is the BK virus from? Nowadays, it's unclear that the BK virus is from the donors to the recipients, or it may be the recipient itself the reactivations. Also, some recent studies, they say the BK virus originates from the donors to the donor's kidney. But some might persist on because there's primary infections of the polyomavirus in their early life, so the virus might spread for the pernicious cells, such as the urothelial and the kidney tubular epithelium. And also, there's only a few cases reported that discuss about the polyomavirus with UTUCs after kidney transplantations. And this is only, there's a few case series that discuss about this topic. And we can find out the average interval between the cancer, the UTUC and the transplantations is not far from our study. They are from 5 to 10 years, and our study for the positive group is 6.1 years, and for the negative group is 5.1 years. So this is a relation. This is the BK virus genotype. BK virus genotype is divided into 3 types: the early region and the late region, and the third is the non-coding regular regions. And the early regions, they encoded 2 antigens. One is large tumor antigen, and the second one is small tumor antigens. And recent study, they are focused on the large tumor antigens because they are placed the essential rules for the virus replications, and also because this is the first protein they encoded during the infections. So come to the conclusion. First, the staging is still the strongest prognostic factors for the UTUC after the kidney transplantations. We find a trend that the early onset of the post-kidney transplantation UTUCs in patients with the positive large T antigen expressions. So we might advise that the patients might more frequencies for a screening of the upper urinary tract for the positive for the polyomavirus infections in after kidney transplantations in Taiwan. Thanks for the attendance.
Very interesting work. Is there any question for Dr. Lin? Can I ask you, do you have viremia data in those patients who show large T antigen? All of them positive. Is there any relationship between the titer of the viremia and whether the T antigen appears or not?
Well, it's not unclear because we cannot regulate to check the urine virus titers or some of the cytology. We just find this trend, and now we have to modify our protocols that we might regularly follow up the urine cytology after the kidney transplantation.
Is polyomavirus infection very common in non-transplant Taiwan population?
Actually, I don't see the exactly data that whether the populations of that.
I'm just wondering whether the T antigen might be found in the non-transplant patients with upper tract cancer.
It might be found in the